Good afternoon. Great to see everybody again. Thanks for being with us. And a big thank you to Doug Holtz-Eakin for being with us.
My pleasure.
Let me make sure this is off. I don't normally carry my phone up here. Sorry. And there's any reason to appreciate Doug being with us. Obviously, he brings his experience from having been the former CBO director and the current president of the American Action Forum. One of the many assets of engaging with Doug is his being recognized as a national thought leader in the economic policy. And I know you won't say that your healthcare policy, but as much as the work that we do at MA, we definitely look to Doug for his wisdom, his input, and his just practical perspective. So very fortunate to have you with us here today. One of the areas that I thought we would sort of kick off with, and it's been a theme throughout the day, we had Dr. Oz earlier today, we had former Administrator Nancy Anderparl, and then we had a panel on health risk assessments, on value-based care, and most importantly, we heard from our beneficiaries. Mm-hmm. And a thread in all of those conversations was the value of Medicare Advantage, our need to protect, strengthen the program, and when we talk about strengthening the program, it's what can we be doing to improve it, but at the same time wanting to protect it from cuts. And as we sort of look at that, there's the thread of comparing MA to fee-for-service. And so, Doug, if you could just sort of speak to what you see as just the fundamentals of the differences there and why we do see more seniors signing up for Medicare Advantage and choosing it.
Sure. Well, first of all, thanks for the chance to be here today. I appreciate it. And thank you for your leadership at BMA. You can answer that question a number of ways. I mean, go back to the beginning. I was at CBO in 2003 when we passed the Medicare Modernization Act, which included Medicare Advantage as we now know it. And that was because fee-for-service wasn't good enough, and there was the need for an alternative. It had value in providing that alternative, and that was pretty clear at the time. It's got things that fee-for-service just doesn't have. It has the flexibility to be a different thing in every piece of geography in the United States, depending upon the population health demands. MA plans can reconfigure themselves, and whatever the delivery systems might be in that area and the networks, they can reconfigure themselves. That ability and flexibility, I think, is a crucial piece of the landscape. It's got a quality metric. I can go on at length how I don't think Medicare Advantage stars is the end-all and be-all of quality metrics. We'll just leave it at that. But it has one. And fee-for-service has nothing, right? Mm-hmm. We have no idea how they're doing. But I think most importantly, if you're an economist, you measure value by what people are willing to pay for and what they opt to use. And a majority of seniors now get their Medicare through Medicare Advantage. They have voted on the value of that over fee-for-service by going to MA. Mm-hmm.
Mm-hmm. Well, and to recognize, as we've recognized with others, when you talk about seniors going to MA, today being the first day of open enrollment, we're now looking to see.
Is that a coincidence, or did you plan this?
Dr. Oz was totally giving us credit for strategically doing this, but I'd like to say our team is terrific.
Did you also plan the shutdown to focus attention on the conference?
Yes, that too.
Okay, good.
We'll take credit for anything. Doug, you have done a lot of writing and speaking, and I should recognize for those of you who are both local and traveling from all over the country, whenever I see Doug on any of the cable networks, I sort of just stop and listen. So he's a familiar face in lots of ways. But because of that, I'm attributing some things that you've written or said. So, but I'm not setting you up. But one recent writing, you had said, there's no analytic case for large systematic waste in Medicare Advantage. And that Medicare Advantage's structure with competitive bidding, risk adjustment, and quality measurement make it fundamentally different than fee-for-service. And I know we were just talking about MA, fee-for-service versus fee-for-service, but in that context, how do you look at how policymakers should account for those specific features as it relates to evaluating value for taxpayers?
Yes. So Mary Beth's talking about something I probably wrote in my morning email, which is
yes.
For the record, my morning email is personal therapy. A lot of what goes on in this town makes me crazy, and I visited upon the readers of the morning email. This is one of them.
Well, yes, thank you. Well, reading your emails is also therapy for us, so it goes full circle.
So the Wall Street Journal had published this piece, which talked about the error payment rate in Medicare Advantage, and never bothered to look up the error payment rate in fee-for-service Medicare, which is nearly twice as large. And so this irritated me, and if you think about the structure that you would want, we want to deliver to seniors and all healthcare consumers high quality care, so there has to be a quality metric in there. You'd like to have incentives for cost control so that high quality is a high value product. You'd like to have lots of choice among different configurations of plans that fit on people's needs, and you want to have the provision of that recognize the differential costs of supplying outcomes to different people because they have more problematic health conditions. That's the structure of Medicare Advantage. That is worlds away from the structure of fee-for-service, which became widely recognized as feeding the bad practice patterns in American medicine, and Congress took steps to move away from it with, a variety of ways. So to just flatly take and look dollar to dollar or error payment rate to error payment rate just doesn't make any sense to me. You're committing a real apples to oranges comparison. The populations are going to be different too, and there's just an enormous amount of effort made to statistically adjust them so you can make the comparison. I don't think we've ever gotten that right, and I don't really trust those comparisons. So I worry when people just casually lob up this number or that number is here. I've identified the waste in Medicare Advantage because in this environment where people want, say hypothetically, to extend enhanced premium tax credits for a year, people are looking for money, and you want to take genuine opportunities to offset, not things that are going to undercut valuable programs. So I'm worried about that.
Well, since you brought up that, I think it was the Wall Street Journal headline, as it related to overpayments. Obviously, there's headlines, and then often policymakers react to those headlines. Sure. And when we sort of see that, we don't want to lose sight of our commitment again to improving the program, recognizing where there's needs for accountability, transparency, and CMS plays a role in that oversight, and it's for, in this case, industry to follow that guidance. As it relates to those kind of headlines, though, grabbing certain policymakers, and this could be, executive branch, legislative branch, there is the commitment to focusing on program integrity. And so how do you think Congress should think about program integrity that's fair both, across both parts of Medicare Advantage and fee-for-service, as it relates to that?
Well, I think first and foremost, they're not the same, and so they're different programs. They're going to have different integrity aspects you're going to have to investigate. And I guess I know what I don't like about what's going on in the program integrity world right now, on Medicare Advantage at least. Going back to the birth in 2003, I've thought a lot about MA. Conceptually, and what we're trying to accomplish, giving a sort of effective market-based alternative to fee-for-service. And the key is to have MA plans able to manage their pools effectively, have to have the pools risk adjusted, and to make sure that they are being given enough in the way of subsidies plus premiums to provide adequate care. We have the quality metric intended to check the adequacy of the care and the outcomes that you get. And that construct is not about any individual. And so in my view of the universe, not currently operating in Washington, footnote, but my view of the universe, you never should need encounter data. You shouldn't be doing audits of the encounters, because that's turning it into a fee-for-service program. That's saying, oh, you met with Doug Holtz-Eakin and you checked out his hip replacement and gave him new statins to check on his cholesterol. That's a fee-for-service mentality. It says you paid too much for the statins, too little for the encounter. That doesn't make any sense. That was not the point. The point was to have plans incentivize providers to deliver the care in the way that made the most sense, in the setting that made most sense, that cost the least money and got the right outcomes, and stay out of it. Then we're not doing that. So I'm worried that program integrity is a word that's being used to cover for damaging the fundamental construct that was Medicare Advantage at the outset. That's the probably too blunt truth, and so I keep an eye on that. I think that's a real concern. Program integrity and fee-for-service is different. You know, the mafia sets up a shop in a local town, bills for a couple of $1 billion, then leaves town. That's an issue. That goes on all the time. And we need to deal with that. The pay and chase thing is not working, and so there are different problems in the two programs.
You said this earlier, just in our short time already speaking, and it's been a constant theme. You prioritize, you know, there's the waste and fraud that needs to be addressed in Medicare Advantage, and we don't, you know, disagree with that. You do say, though, that the answer isn't to just immediately go and say we're going to reduce MA funding to offset other priorities like tax cuts, and seeing that that's misguided. How do you see what we need, and we saw this happening during the recent reconciliation effort, and any time between now and the end of the year, and could carry over into next year, the same challenge?
So this goes back to my CBO days. One of that was one of the greatest jobs anyone could ever have, and I was genuinely honored to have it, and I loved it. But it's a weird job in that it's just about the budget, and it's not about the policy. And what I quickly came to recognize was that there were good and bad policies that could produce the same budgetary outcomes. And if you only did it based on budget, you could make a lot of mistakes. So it's easy to save money in federal health programs. Don't pay for things. Create a really bad insurance product that doesn't cover anything. It's really cheap. It looks good on the budget, but it's not the answer to a policy problem. And that rule of thumb is always I've used, and what I've realized is that anytime it gets to a reconciliation process or an end-of-year process where the scramble is for money, if you do health policy just to get the money, you will do bad health policy, almost for certain. It's an environment that is really rife for that kind of thing. And so I worry about any time they say, oh, Medicare Advantage is on the chopping block, Medicare's on the chopping block, we're going to put the CHIPS program on the chopping block. That phraseology leads me to really worry about things. There are reforms that can save taxpayer dollars. I'm all for that. But do them in a thoughtful way in advance. If you're just grabbing money at the end, you're making a mistake.
So to go a little deeper on that theme, because ironically there is a current piece of legislation right now, the No Upcode Act, that has been discussed a couple times today. I think more recently in a panel that we had on in-home health assessments. And that legislation is, you know, one of the areas that's being seen as identifying savings that could address some funding challenges. And to your point, is it addressing a funding issue, or is it addressing a health issue? And I think, you know, folks would disagree with that. If you can just speak to why that legislation would be bad policy for taxpayers, and then just also not good politics for members of Congress.
So the whole issue is, are you going to take the money away because it's inappropriate billing to CMS for an MA patient, or are you going to take away necessary resources to treat a less healthy individual? And you can't tell that apart sitting in that chair, and I can't tell it apart. And that's, as a result, not a problem with the behavior of the plan. That's a problem with the program design. They're putting plans in a position of being accused of this by having the risk adjustment structured where the person comes in, you then look at them, give them a risk score, and off you go. If I was, rethinking things from the start, I think they should think about this. People have a risk score. The people you sign up have risk scores. You treat them. You find out things about them in the course of treating them. They exit with perhaps a new risk score because you found out some things. But you don't get to immediately get more money up front. That puts the plans under the gun and under the suspicion, again, of doing something inappropriate. And again, you're looking at individuals. You're saying, how are you treating this individual? And that's a fee-for-service mentality. You don't do that. We gave you a pool of people with risk scores. You have some money to cover those costs. You do it really, really well. We look at your quality, or you don't, and you go out of business, and that's the fate of the plan. And then we find a way to update those risk scores appropriately for what we learned about people's health. I think the trouble is the UpCode Act is the solution to no problem. The problem is the program design. The UpCode Act's a money grab, and I just don't think that's a good idea.
Well, and just as you say that, we are looking, when you talk about, you got to focus on how legislation like that's affecting the beneficiary.
Yeah.
And that is something that we are looking at right now, an analysis on just what would the impact and most likely negative impact on beneficiaries. So a bit of a preview of data forthcoming.
So again, in my view of the universe, you come in and you find out that what we did know is, like, I have a cardiac condition. So you're like, we find that out not by doing a home health assessment, but I go in for my very first treatment. They look at things and say, oh my God, you have this thing. You don't then get to stop treating me as an MA plan. You treat me. And if you don't, you should get a really terrible quality score, and you should be penalized for that, and all those things. But you treat me, but I'm now recognized as a much more expensive risk for the next year, and for that year, the plan has to somehow get insured against that. So I would insure the pool, not the person, and just make sure that the plan isn't penalized inappropriately because of a bad draw. I mean, and so that looks like more like risk corridors, as we had in the Part D program, than it looks like individual reinsurance. There are lots of ways to do this,
right?
But the way we're doing it now, I think, is uniquely the wrong mix of tools.
You have pointed out, again, in your speaking and writings, the previous administrations made some policy changes that have been harmful to MA, and recognizing also at the same time the high utilization costs and medical trends. And some of that we're seeing right now where it is happening. We just had the CMS projections out, and we just had analysis come out yesterday where we are seeing an increase in out-of-pocket costs and plan closures. What lessons do you think we should be taking away from previous administrations, whether it's cutting the program, making policy changes, that we should be looking as what's the right framework for MA reform going forward?
So in the larger scope of what we've seen, if you go back to sort of the election that I worked on with John McCain prior to Barack Obama's election, that was a time of vigorous bipartisan debate about broad healthcare reforms, where the two central issues were enhanced coverage and, quote, bending the cost curve, delivering more high quality care, however you wanted to frame that. And you got to the ACA debate, and in my view, essentially they chose, let's cover people, we'll do the cost control thing later. And it's caught up with us. There's been all these coverage enhancements, and often the coverage enhancements come with the inability to manage costs, inability to do prior auths, inability to do all sorts of things. And so you take the tools away for cost management, you should make sure you cover everybody with bad incentives, and it gets expensive. And now it's getting expensive. And so I think the second wave has now come where we're going to deal with, sort of broadly, with the cost control issue. And that should be the top priority right now, and it should be thought about that way. And the Biden administration was very much still in the mentality of expand, march towards single payer, or however you want to characterize that. We're just going to cover people. We're not going to worry about what it costs. I don't think we can afford that.
Well, and just as you talk about cost control, shifting a bit to just preserving solvency.
Oh, you dreamer.
I know. If you were advising CMS in Congress, what would you be saying both for Medicare Advantage and Fee-for-Service? What couple reforms do you think that they should be focusing on through the lens of improving value for taxpayers?
I mean, with MA, again, I think the capitated payment, risk adjustment, quality metric, that those are the ingredients of what can be a very successful program. But we need to do all better. And talking about risk adjustment is boring, but essential. sort of how you can manage that. If I could do one thing, I would take the Medicare Advantage STARS program and turn it into 10 things, maximum 10. Give me 10 things, process, outcomes, something that is clear, transparent, understandable, doesn't drive reimbursement, but drives penalties. If you can't hit these metrics, you don't get paid. And that's that. And allows seniors to identify plans that hit metrics, provide quality care, and those that don't. That's all it should do. They try to do too much with it right now. Clean those things up. On the fee-for-service side, make it compete on a level playing field with MA and see how it does. So make it compete usually means some sort of bidding system where you sort of have the fee-for-service system bidding. I have no objection to that. We can do that. But make it have a quality metric. Right? If we're going to demand quality of care, do it across the board. Have a level playing field and let people pick and see how we do. Because that we don't want to just save money. We can save money by not covering people. We want to cover people, deliver high quality care, and save money. And we need the tools in place to do that.
I'll give some time for a couple more questions. One is recognizing, again, on the day of open enrollment, that we have over half of the Medicare population choosing Medicare Advantage. And also what's exciting is any poll that we've done, others have done, there's a high satisfaction rate among those seniors in MA. And the other that shouldn't be overlooked is that seniors choose to enroll in MA. They're not automatically enrolled. It's something when Nancy Enderpaul was on, we discussed that as well. So it's an intentional choice by the senior on their own, family members or caregivers. And you have talked about Medicare Advantage, being the program that is the better foundation to build the future of health care. When you look at that future, what do you see as, maybe the three most important things that need to be understood about MA's value? And we can generically talk about affordability, quality, the benefits, but just, to drill down when we think of just where we are right now in healthcare and where we need to go, what do you see as critical as the value of MA in that foundation that you're referring to?
So it's a value-based system, a managed system, and that's important, but it's not the same one everywhere. We know that different plans have like supplemental benefits versus lower premiums. People get to pick which they like. I'm all for that. Choices are at the heart of effective competition and cost controls. It will look different in rural areas than it will in urban areas. It'll look different in the West and the East. One of the things that is, I think, least genuinely it's recognized but not appreciated in the discussion of American healthcare is the huge heterogeneity of our population. We're enormous. We're very different across the globe. We have a history of heterogeneity, public health systems, religious health systems, Indian, Native American health system. We have children's hospitals in a way that other people don't, and that happened for a reason. And we should respect that heterogeneity and build programs that can adapt to it. And MA can do that. And I, because I'm a soulless economist, think it's great if people go out of business. And if they don't deliver, we should let them go out of business. And MA plans will fail. Fee-for-service will never fail. They can be horrible, but they can't go away. And if you build the future on something that can't go away, it's not going to be as good. So those to me are important features. Recognizing the heterogeneity, allowing people within that to get a high value care, and part of that is holding people's feet to the fire, which is uncomfortable if you're in business. It's but it has worked.
Well, Doug, thank you so much for being with us today.
Thank you.
I have a question.
Sure.
Do you have an easy question?
Is this?
Yeah, I hope. Maybe I tend to.
So we have another question. She's on.
One, I absolutely love your style and your directness because give it to me.
That's why we allow this question to occur.
Yeah.
Oh, okay.
Number two is that right now, when it comes to MA specifically, you have hospital systems that are playing a game of chicken with the plans and the carriers to get as much as they can from them monetarily. This is creating more and more of an abrasion to the senior, basically scaring them that they're going to lose their doctor. And in some spaces, it creates a place where there is no hospital system in network for certain carriers. What do you see happening, or what ideally in your world, how do we fix that? Because right now, there's nothing on the table saying, you guys can't play like this, play next to the sandbox.
So I'm going to give you a classic wishy-washy economist answer. Genuinely, there should be out there in the universe some very hard-headed negotiations between plans and all the providers, hospitals, doctor groups, pharmacies, name it. That's part of life, and I don't think that's inappropriate. If there is abuse of market power by any part, that's an antitrust violation and should be treated as such. And I'm worried we've got a lot of that going on right now.
Yeah, we do.
But that's not an MA problem. That's a competition problem in the health sector that someone ought to get serious about.
Thank you. Doug, thank you so much.